All right. Okay, cool. Looks like we're live. All right. Hello, everyone. Welcome to the very first eShadowing session. My name is Caesar. I am the creator of the eShadowing program, and I'm just super excited to really present you this opportunity to gain some shadowing hours and to overall expose yourself to the healthcare field and learn about the various specialties that exist in medicine. I know during these times it can be difficult to really gain physical shadowing opportunities because of COVID-19. So I'm really excited to present this opportunity to you and to make sure that you get the most out of these presentations so that when we come back to normal, you'll be able to basically engage in physical shadowing sessions and have this well-rounded foundation of knowledge with these specialties. And you'll be able to, have some good organic conversations with these physicians. And yeah, that's the overall goal of this program, is just giving you all the knowledge that you need to not only apply to your med school application, but just to have that knowledge to really build on top of, when you're actually seeing physicians. So yeah, I just want to thank you all for coming here today. And joining me, I also have the virtual shadowing facilitators for the spring session. Just feel free to introduce yourself, guys.
I can go first. Hi, guys. My name is Pema Sharpa. I am one of the facilitators for this program. I am currently at UC Davis studying biochemistry, and I'm really excited to be in this program, helping you guys.
Okay.
Alrighty. Hello, everyone. I'm also excited. And my name is Nima Sherpa, and I'm also at UC Davis majoring in global disease bio. And I'm really excited to kick this program off with Caesar and Pimba and everyone else behind the scenes. So thank you for joining us.
Yeah. And I want to thank everyone at Pre-Med eShadowing for really helping us put this together so that we can give this to you. And without them, this would have been a very monumental task to really achieve. So I want to thank everyone at the Pre-Med eShadow team for just helping, contributing, and making this a reality for all of you. And with all that being said, I want to introduce all of you to Dr. Ahmad. She is a third-year radiology resident, and she will be sharing her passion for the specialty and basically, telling you her journey to medicine. And yeah, Dr. Ahmed, whenever you're ready, feel free to take it away.
Definitely. Okay, perfect. So thank you guys so much for the introduction. Um, I just want to make sure before I get started that everyone can see my slide. So just give me a thumbs up that you can see my slide. And then also if you can hear me okay. Is everything good? Yes. Okay, perfect. So thank you all for having me. It's really a pleasure to be here. And it's a Saturday, so I know that so many of you guys are taking out your time on a weekend, on an afternoon, on a Saturday nonetheless, which is a huge deal and just already shows how impassioned you are about your future and your career, which is really, really says a lot. So there's a lot of pressure because I'm the first one. And so I really, really want to make this great for you guys. But I'm going to start out just with some general stuff because I know this is the first in a series of several shadowing sessions that you guys are going to have. So I'm going to sort of give you an overview of different specialties as a whole, and some of it's going to be kind of funny. So, but before I jump into that, let's see. Is my slide not moving? Okay. So just a little bit about myself. So I'm originally from Atlanta, Georgia. I went to undergrad at the University of Georgia. I did their honors program, majored in biology and ecology. And then I stayed local for med school. I went to the Medical College of Georgia. And then I stayed local for my intern year. I did it in Atlanta. I got married while I was in med school, and my husband's family is from the Northeast. So I ended up in Long Island, which is where I'm doing my residency right now. So if you just add up all the years, not even including my residency. It's almost a decade that I've been doing sort of this, and I'm still not done. So it's a long road, just for everyone. It doesn't matter if you're doing a short specialty or short residency or one of the longer ones like neurosurgery. It's a long road for everyone, and if you're looking for something that's like immediate gratification, medicine's definitely not that career. It takes a lot of sacrifice, many years of dedication before you start to see the fruits of your labor. But I will tell you that along the way, there are so many little moments that are going to convince you that you are on the right path. And what I want you guys to remember is look for those moments and keep those moments close to your heart and in your memory, because in your dark times and the sort of moments where you're like, oh, I don't want to do this anymore, you're really going to want to hold on to those moments, because as you can see, it's a long journey. And then this is a slide that someone made. Unfortunately, I don't know who made it, so I can't give them credit. It was not me. But I think it's funny because it's kind of depending on how you take it, accurate or inaccurate. I don't know what medical specialty to choose. And it's funny because if you go down there, it talks about, are you socially awkward? Yes, you go into radiology. And I can tell you, for one, I am super social. I go out pre-COVID all the time. We have happy hours in my residency. I hang out with my friends ad nauseum when I'm not working or studying. So, but it's just, there's so many fields and there's so many biases that you'll hear about them. People will tell you, oh, it's based on your grades, then it's based on whether or not you like surgery or whether or not you like kids or your social life or what you like to do in your free time. And I'm here to tell you that you're going to hear all of those things sort of maybe even in subsequent shadowing sessions and probably even 1 year in med school. But at the end of the day, it doesn't matter. Whatever you want to do, even if you don't fit those biases or you don't fit that mold, you can do it. And I'm a shining example of that because I definitely don't fit this socially awkward radiologist. And then this is also sort of a funny one that I came across. It's basically medical student perceptions of different medical specialties. And someone actually did a research project on this. And basically under each subspecialty, whatever word is like sort of the largest, that's sort of how people perceive these different subspecialties. So I'm not going to go through all of them. I'm just going to point your attention to the radiologist. Again, boring, reclusive, lonely, spooky, meticulous, alone, intense. I do like my alone time. I can be intense, but I'm definitely not a snarky hermit, that's for sure. Again, like I said, you'll hear all of these, but it's people's perception, right? Like if you meet someone at a gas station, I mean, that's your perception after hanging out with them for 5 seconds. You don't actually know who they are on a day-to-day basis. So again, you'll hear these things. Don't get biased. Keep a very open mind as you're going forward. That's something I just wanted to tell you guys. And so with that said, radiology is kind of one of those fields that people don't really get exposed to at your level for sure. And then even in med school, you'd be surprised how few people get exposed to radiology. And what I wanted to emphasize with this slide is that there's so many different subspecialties in radiology. If you want to interact with kids, you can do pediatric radiology. If you want to do more surgically oriented stuff, you can do interventional radiology. If you're interested in like the fast-paced, what emergency is going to come next, you can do emergency radiology. If you're interested in like the bones and reading MRIs of the spine and shoulder, you can do musculoskeletal. If you're interested in breast cancer, there's breast radiology. So there's a vast sort of spectrum of what you can do within radiology. And so don't feel like this is just a field that's one person sitting alone in a room, isolated, and just reading chest x-rays all day, because that is certainly a very inaccurate picture of what we do. So I want to sort of jump in. I've given you guys kind of an overview of different medical specialties, hopefully from a humorous perspective, and then also, a broader perspective of radiology. The next few slides, I just want to talk a little bit about some of the terminology that we use within radiology. And then the next section is going to actually show you guys some cases. So before we jump into that, I want to talk about this term right here, modality. So you'll hear this word thrown around a lot, like especially in med school, people will say, oh, what modality are you going to use when you image? What's the best test? And essentially what they're talking about is these things right here: radiography, CT, MRI, radionuclide imaging, ultrasound. And what differentiates all of these is sort of goes back down to physics. And I know that if you're in college, if you're still, in high school or undergrad, you're probably like, what the heck? Why do I need to know physics to be a doctor? Actually, for radiology, you do need to know some very basic and fundamental physics, because it boils down to this: how we get the images, how we get the CT, the MRI, the ultrasound, boils down to the physics of the modality. It's nothing crazy. It's definitely not like the acceleration due to gravity stuff that you have to learn in college, but it's there. And again, when I mention modality, at which I will do several times, this is what I'm referring to. All right, so next, so the thing I wanted to talk to you guys about was, how do you approach an image, right? Like if I put you in front of a computer and just put a picture up in front of you, what are you gonna do? Like, what's sort of the thought process? What's the approach to that image? Because if you don't have an approach, it gets really confusing and you could just kind of find yourself all over the place. And so every radiologist that you talk to, everyone that's trained in this sort of has a similar approach, not identical to mine, but they're going to go through this process or something similar in their head every time they're faced with an image. So the first thing is what we just talked about, the modality. What am I looking at? Am I looking at an ultrasound? Am I looking at an X-ray? Am I looking at a CT or an MRI? So you got to figure that out first. Then you want to look at how is the image acquired. So when you work in a hospital, you're going to have very, very sick patients in the emergency room, in the ICU, maybe even in the PACU post-surgical unit. And then you're going to have patients that are kind of sick, but they can get up and walk, And so what I mean by this image acquisition is if your patients can come down to the radiology department and they can get their image acquired there, we're going to be able to get it the way that we want it to optimize what we can see. And if they're not, if they're super sick, they can't move, we can't reposition them, then we do what's called a portable exam. You can't do portables with everything, but you can definitely do like portable chest x-rays, portable x-rays of like the feet, the hands, any other body part. So that's what I mean by image acquisition. And then history and chief complaint. So these are things you're going to hear a lot about when you're in med school, is the history. So why is the patient here? What brought them to the hospital today? Was it a fever? Was it chest pain? And out of all of those things, what is the primary complaint that they have? And that's going to be your chief complaint. So you do want to know that, because that's going to help you narrow down what you think is going on based on the imaging. And the last two things are a search pattern and pertinent positives and negatives. Again, when you guys get into medical school, you're going to hear about these things ad nauseum, and we still use these as radiologists, because at the end of the day, we're doctors too. So we use them to help us interpret images, and we're going to use this a little bit more. So the next thing I want to talk to you guys about is planes. When you start anatomy, this is something they're going to hit on again and again, is what plane are you looking at something in? Is it the coronal plane? So the coronal plane is when you slice something from like the front, from the tip of your nose all the way to the back of your head, the back of your body. And a sagittal plane is going from side to side, and the axial plane is going from head to toe. So again, if you don't know these, it's no big deal. It's just something to think about, understand, because it plays a part in how we image patients and how we make reconstructions and all of that. All right. And the final thing before we jump into imaging is talking about descriptions and descriptors, right? So I kind of like to think about radiologists as like the doctor's doctor, because we really, if you think about it, right, the primary doctor, the surgeon, they've already, right, they've talked to the patient, they've interviewed the patient, they've examined the patient. Now they still don't know what's going on, so they're ordering imaging. And at that point, we're now saying, okay, based on everything you know, what else can we tell you without opening up the patient and just doing a scan on them? And so, but the next step is we understand that, we use our terminology, but how do we communicate that to the doctor? And that's where the descriptions come in. So when you're a radiologist, I mean, we spend 5 years in training, which is that it's actually one of the longer residencies of all of the specialties that there are out there, is partly to make the findings and partly learn how to describe them well. So I gave you guys a few simple examples. The first one is probably the easiest, right? So we're talking about the heart is grossly enlarged. Sometimes the heart isn't super enlarged. Maybe it's only mildly enlarged. It's an early sign of heart failure. Or maybe it's super enlarged compared to what you saw 2 weeks ago, and now you're worried about like a pericardial effusion. So all of these things are going to play into, your descriptions are going to play into what the likely condition of the patient is. And again, no active lung lesion. That's just an example of showing how you can say, like, let's say they're looking for a pneumonia, right? Well, you don't see anything, so you say no active lung lesion. That doesn't mean the patient doesn't have pneumonia. It just means right now, at this moment, you don't see anything in the lung. So again, just a couple of examples of how we communicate our findings to the physicians who are ordering these studies. So now I really want to jump into the meat of the presentation, which are going through some cases. And I want to emphasize that radiology is a very visual field, okay? So we can talk for hours and I can talk to you about words, descriptions, anatomy, but at the end of the day, the only way that you get really good at this is by looking at tons of cases and tons of examples so you understand what's normal and abnormal. And what I'm going to do, as you'll see in the next couple of slides, is I'm going to show you examples of normal imaging modalities and then abnormal. And I don't expect you guys to come up with specific diagnoses. That's not what the purpose of this is, just to give you a sample of all the different things that we can see on a daily basis and what's the way that we approach each image. And you'll see that there are similarities and there are some differences. So let's start with our first case. So this is a chest radiograph. Remember, the first thing we want to look for is the modality. So this is an x-ray. We're looking at the chest. And then you want to look at you want to do a search pattern, right? So everyone has a search pattern that's slightly different. For me, I look at the lungs first. And so I compare, symmetry is your friend in radiology. I always compare side to side. And just look, and I see that the lungs look pretty clear. The next thing I look at is the heart, and the heart here, the heart borders look fine. And then I look at the diaphragm, borders of the diaphragm, beneath the diaphragm. Then I look at the bones, the clavicles, the scapula, the anterior and posterior ribs. I look at the thoracic spine, and then I look at the soft tissues. And that's it. And I don't see anything abnormal here. So I'm good with calling this chest x-ray normal and moving on. So this is a different example, same modality. We are an x-ray of the chest, and this is a frontal view. So if you want to talk about planes, this is a coronal plane. And a description. So we have a large airway consolidation in the right middle lobe. This patient had a history of fever and chills. So I feel pretty comfortable calling this a pneumonia, okay? And again, as if you decide to go into radiology, we'd get more descriptive and say this is like a right middle lobe pneumonia, but that's a little too advanced. I just want you guys to get used to this process: modality, imaging plane, descriptor, and taking into account the patient history. So that was simple. We'll move on to something a little bit more complex. So this is a CT scan. This is a coronal plane, okay? So we're imaging front to back. And I'm just gonna point out some anatomy here, okay? So this is the liver, you have your portal vein here, gallbladder. This is the stomach, part of the spleen, small intestine, large intestine, bladder. And then you've got your pelvic bones, the top of the hips. We've got normal thigh musculature here. We've got the bottom portions of the ribs, the inferior portion of the heart, and then the black area here is the lungs, the bottom of the lungs. So I don't see anything abnormal. So in this particular slice or section of the CT, I would clear this and say that this, from this slice, it appears normal. Now in real life, when you're doing cross-sectional CTs and MRIs, you have to scroll through multiple slices. But again, very advanced, we're not going there, just an example. So now this is again a CT, that's our modality, coronal imaging plane. And our descriptor here is we've got a large encapsulated heterogeneous mass with enhancing septations in the liver. And that's how I would describe this. The history in this case was an asymptomatic patient. And so the diagnosis for this was a liver hemangioma, which a lot of people don't even know they have. You'd be worried, oh my gosh, this mass is so big, this patient has a cancer. This is actually a very typical presentation for a liver hemangioma, which can sometimes get this big in some patients. So same idea, same deal. And, you know, even in complex cases, if you use the same process, it's going to help you. And as you go on in training, you add on to this. Okay. So here's another example. We're moving modalities now to ultrasound. This is a sagittal view of the uterus. And I'm just going to point out something to you guys. Do not be alarmed if you just look at this and you're like, what is going on? I have no idea. Ultrasound is really one of the hardest, most challenging modalities for a lot of people, even radiology residents. It took me a long time. I was terrible at it my first year. So it's totally fine. I'm going to orient you and we're going to go through a fun case. So this is a normal ultrasound, a sagittal view of a female, and this is the top of her uterus. It curves into her vaginal canal. Anterior to the uterus is the bladder. And so this is normal, right? So I don't see any mass here within the wall or the endometrium of the uterus. I don't see anything obstructing the vaginal canal. The tissues around the uterus look pretty homogeneous, and, you know, I wouldn't say there's anything remarkable here. So now here, we again have a sagittal view of the uterus, but we are now seeing a yolk sac with a fetal pole, and this is a female that missed her period. So this would be very classic for a intrauterine pregnancy, okay? So again, like I said, repetition, seeing tons of these images, knowing what to look for and pertinent history, that's what's gonna make you really good at this if that's what you decide to do. So I'm going to end with this just because I think it's a lot of people don't know that radiologists do mammograms. So if you know anybody that was diagnosed with breast cancer or goes to get annual mammograms, this is what they have done. And so what you do is you take the breast and you compress it in the mammogram machine and you get an image like this. Now this, we have sort of different planes than the standard axial, coronal, and sagittal planes. For mammograms, we use something called craniocaudal and medial lateral oblique. Way too much for your level. Just know that that exists. But I would describe this as pretty normal anatomy. So this is your pectoralis major muscle. This is the nipple here. This is all the skin of the breast. This is some retroareolar breast tissue. And then just normal fatty replacement of the breast. I don't see any masses that I would be concerned were cancer. So now this is a different case. Again, this is a mammogram. This is craniocaudal imaging plane, and we see a spiculated mass in the lower outer quadrant of the breast. This patient did have a family history of breast cancer, and so the diagnosis was a breast cancer in this patient. So that's all I have as far as examples for you guys. I just want to end with a few pearls, hopefully convincing you guys to go into the best specialty ever. And it's that just think about how freaking cool it is that 100 years ago, we could not look into the body without opening it up, either through surgery or through an autopsy after the patient was dead, and tell you what their inner anatomy looked like. We literally could not do that. You had to do surgery, you had to amputate, or the patient had to be dead and do an autopsy to get the sort of information that we're able to get now. And our ability to now do this through advancing technology, our control and our understanding of radiation and other imaging modalities, it really puts us in a position to be like physician detectives and solve diagnostic mysteries that, the clinicians who are seeing the patients really can't tell, or even the surgeon, if they've done a surgery and they're like, now the patient's deteriorating, how can we know what's causing their deterioration without going back in? They order a CT scan. So, and the other thing is radiology and medicine are so vast. When you guys, enter into medical school, you'll see that there are things that we do now that people didn't even know existed like 10 or 15 years ago. So you have to keep learning. As medicine evolves, we have to evolve, we have to continue learning. And that's really applicable no matter what specialty you go into. You'll see the best doctors, they're not the ones who finish residency and just say, I know everything. That's it. They're the people who are in their like 50s and 60s and who still are learning new stuff, who still have the curiosity to look things up or to try to understand something that they haven't seen before. So stay curious, and remember it's a lifelong learning process. This is just a funny quote. I hope you guys choose radiology in the future, learn to see inside each other. I also want to give a huge plug for social media. If you guys at this point in your career are not taking advantage of social media, I highly recommend it. Med Twitter is a great resource. If you guys want, you can follow me there. That's my Twitter handle. On Instagram, that's my my Instagram account. I just think it's a great way to network, to talk to people who are in different fields. And you'll see Twitter is sort of like more academic chatter. It helps you to get involved in like the national leadership organizations within your field. So I do recommend it for everyone, especially if you're sort of wanting to go into the more professional realm of networking. And a lot of people, when I do these sort of sessions, always ask me for advice. And my advice, it's the same advice I always give. It's network, network, network. Let me tell you that at the end of the day, everyone's going to fill the check boxes that that are required for med school, right? You have to do your prereqs, you have to take the MCAT, you have to have like a certain threshold of grades, you have to, you know, get the research box filled, all of those things. And there's so many people who are going to have that. But what sets you apart is networking, is talking to people, it's sharing your passions, it's sharing some of these things that you guys are doing with other people, so that they know how much you care and what you're passionate about, so that when it comes time for the selection committees to sit down, they'll be like, yeah, I know that person, I talked to that person, oh, I know they're active on social media. So that's really my advice for you guys, and I'm happy to connect you to people if there's a field that you're interested in, or want to, you know, show up on Twitter and have, I'm happy to make introductions for anybody. So do reach out. And I'll leave you last with this inspirational quote. I know you guys can't see me in real life, but I'm actually like super tiny in person, like 90 pounds. I'm very small. You know, and a lot of people along the way and in my journey have just been like, oh my God, like she's a twig, like she's not going to be able to make it, you know, like, and I've heard so many things that, you know, you kind of like roll your eyes at. And at the end of the day, I just put my blinders on and I'm like, you know what? Everyone's going to have something to say. And for all of you out there listening, like, it doesn't matter where you come from, who you are, what your past is. You know, if you failed a class, okay, fine. You made a C in something, okay, fine. Those things don't define you. What defines you is, do you believe you can make it through this point and whatever lies ahead of you? And you should believe that. You should believe that you are capable of doing all of those things. Because if I can, and I can, and I did, and I still am, I know you can too. And that's it. Thank you again for your attention. I hope this was useful. And I appreciate all of you being here. So with that said, let me, I'll take questions. Let's see, I need to go back onto the YouTube chat. So give me just 1 second. So.
Okay, if any of you have questions for Dr. Ahmad, please post it in the chat. We'd love to hear what you have to say.
All right, so let's see. This was definitely one of the more informative shadowing live streams. Never thought I'd be intrigued by radiology. Oh, wow. Thank you for that. I appreciate it. What is your least favorite part of the job? Okay, so least favorite part of the job. Let me just tell you this, that my brother's in med school, and I talked to him about this a lot. There is no such thing as a perfect job in general. No matter what you do, whether you're in medicine or you're outside of medicine, there is no such thing as the perfect specialty or the perfect job. There's always going to be parts of it that you hate or that are frustrating. But in general, as long as there's more stuff that you like, and there's more gratification from those things, it balances out. It's just like life. But as far as my least favorite part of the job, I would say it's the assumptions. I think, you know, earlier on in the slides, I talked to you guys about, you know, the assumptions that people have about radiology. I think a lot of people, even not medical students, carry those assumptions that, you know, you're sort of socially awkward or weird, or like, you know, you like to spend your time like, you know, just doing weird stuff. And it's hard to sort of battle all of those assumptions all the time because you're busy, right? Like, I'm going to work, I'm trying to do work. I'm trying to get my stuff done, deal with all of the different things that are happening when I'm on the job. But it's hard to constantly battle those assumptions. And sometimes I feel like, why do people have to make, those assumptions about us and our specialty? But then, as I talked about, it's with every specialty, and you just have to realize that people think what they're going to think, and you do you. So that's what I would say. And there's other things too, but for me personally, that's kind of the most frustrating thing. Let's see. Okay. Next question. Do you have any advice for non-traditional pre-meds or those with lower scores / MCAT scores? Also, how is the work-life balance with radiology? Okay, those are two great questions. So first one, advice for non-traditional pre-meds. First off, I would say that you're probably actually in an advantageous position to some degree, because a lot of people who take the non-traditional route have sort of an interesting story that sometimes people like myself don't necessarily have. I had a pretty boring route. I went straight through, high school, college, med school. And so I really, outside of the generic things, checking all the boxes, I didn't really have like a great story, but non-traditional people generally have some interesting life experiences. So I would definitely talk about that. If you're a parent, if you're, if you've seen someone with like a life-altering illness, if you've done some cool traveling. I remember we interviewed a candidate like last month for radiology, and he was like a surfer. He took 2 years off and just traveled the world surfing. And everyone loved him, even though he was non-traditional. They just thought like he was cool because he just surfed for 2 years and traveled the world. So you don't have to have a crazy story like that. That's not what I'm trying to get to. But my point is like leverage sort of the experiences that you've had and what you learned from them, because a lot of times people like myself, it's like we don't really have life experience. We're just kind of dry, boring people. But I will say, like, I had time, I took time off between med school and residency. So I actually sort of did have an interesting story about how I matched into radiology. And that's kind of come up a lot during my fellowship interviews. So there's always a way to leverage being a non-traditional candidate. And I think in this current environment, it'll probably work in your favor. And I'm happy to talk with you about that offline if you want to share your experiences. So just reach out. I think the next question was about work-life balance. I think this is probably one of the most underrated parts of radiology. You get to sit down all day if you want. If you want to take a break and go out and get coffee, that's fine. If you want to be on your feet and do procedures all day, you can do interventional radiology. There's so much variety. If you want that fast-paced lifestyle, if you want a more surgical lifestyle, you can choose to do IR. If you want a more relaxed 8 to 5 sort of job, you can choose diagnostic radiology. If you want to be on call, you can choose emergency radiology. If you don't want to be on call, you can choose another specialty like breast imaging. There's so much variety, and I really think because a lot of people, historically radiologists didn't do stuff like this. I don't know why, but so people just really didn't know what they did or how their life was. And I'm here to tell you, it is an amazing life. And whatever you want to do, your hobbies, if you want to keep up with them, if you want to have new hobbies, if you want to spend time with your family, it's a great specialty to have all of that. Okay, so let's see. I see some more questions here. Is there a lot of patient interaction or relatively minimal compared to other fields? So patient interaction, again, like I said, it's what you make of it. If you want to see patients all day, interventional radiology, breast radiology, even pediatric radiology. Those are great fields to do. If you don't want to see patients because you're tired, you could have diagnostic radiology and just, be reading from your screen all day. There's a lot of choice in how you want to design your life in radiology that I don't think is available in other specialties. So that would be my answer to that. Let's see. Oh, you're welcome. Thank you for the thank you. All right, so let's see. How would you recommend preparing for med school interviews and fellowship interviews? All right. So preparation, it depends. Okay, so number one, are you interviewing right now in this virtual climate or in person, right? So regardless, practice is really, really important. And I'll just tell you, like, so when I interviewed for residency, I interviewed at like 30 different programs. I was exhausting. And my first couple, I really didn't feel like I gave great interviews because I was just starting. I was just getting used to it. And you're getting used to the types of questions they're going to ask you. So there's a couple of different resources. I actually recently created a guide. The AAMC, I'm one of the resident representatives for that. So we just put out a virtual guide for interviewing for med students and pre-meds. They're going to post it to their website soon. If you guys want early access, I can just like email it to you. So reach out. But that's a resource I would use. Just practice for virtual interviews. I would definitely like get on like, just interview yourself. Just open up like a Zoom that you created and like just practice like, looking into the camera, that sort of natural contact, eye contact and things like that. And then, I think it's important to know how you come off in interviews too. Because I think a lot of people, right? Like we know ourselves, we know like, oh, like I'm a nice person, I'm a cool person, but the person on the other end doesn't know you like that, right? Like this is a very short frame of time in which they're trying to get to know who you are. So you don't want to come off as arrogant. That's number one. You don't want to come off as any extreme of any personality. You just sort of want to come off as like an average, nice, normal, humble person that you'd want to come with. Like right now I'm talking to you. Hopefully all of you guys would be like, yes, I want to go out to happy hour with her, right? So, or something like that, right? Because you come across as natural and cool and just a fun person to jive with. So make sure you know how you're coming across is my number one advice. Practice. And then also just get an idea of what some of the most common questions are. And again, that guide that I talked about that I created, that lists some of the most common questions. So strengths, weaknesses, why do you want to go into medicine? Tell me about a time you failed, a challenge, those types of questions. And you can just Google that and find like top 10 questions or something and just sort of be prepared, because the worst thing you want to do is like they're asking you a common question, like tell me about yourself, and you're just like fumbling for like 45 seconds, which trust me does not work out. So that's my advice. Okay, let's see. Thank you for speaking with us. I'm aiming to, interventional radiologist. Nice. You're welcome, Lizzie. Thank you. How competitive is radiology? So that's an interesting question. So radiology, I don't know if you guys have heard of like the ROAD mnemonic, ROAD. So it used to be this thing. I don't know if it still is or not, but it's radiology, ophthalmology, anesthesiology, and dermatology. And it's sort of like, those are like the 4 subspecialties that are like the best lifestyle and work-life balance and, you know, in terms of like career prospects, it's pretty good. So I would say that it was diagnostic radiology was extremely competitive. Like I would say like 10 years ago. It's still in the upper echelon of like competitive specialties. You still have to have like good grades and, you know, decent step scores. If you guys don't know, recently, interventional radiology split, so it's its own subspecialty, and that's even more competitive. So if you're applying for a direct pathway into interventional radiology, then you really have to have like a stellar application. But again, I also want to emphasize this to you guys, because I feel like too often everyone just goes off like, oh, you have to have the perfect grades and scores. That's fine, but I still think 99% of it is networking. I do. Other people might tell you slightly differently. I'm not saying like you want to go in there and like fail every class and do terribly. You do need to work hard. You need to be solid. But some people take the idea of competitive specialties to an extreme. And I'm just here to tell you that you might not have like a 99th percentile in every single class, and that's okay. Like you can still do what you want to do. Take advantage of your network, leverage the people you know, reach out to them, and just keep expanding that network, and you'll be able to do it even within you know, within competitive specialties. All right, so Afreen said thank you, so you're welcome. How important is having research experience as a pre-med versus clinical experience? Okay, so research versus clinical experience. I would say clinical experience is more important. With that said, honestly, as a pre-med, neither. Because, and the reason I say that is really like you're going to get all the clinical experience you need when you're in medical school. The purpose of shadowing is for you to decide, hey, like, can I stand being around patients all day? Can I stand like, you know, the environment of medicine? That's really what it's about. You know, the difference between someone who has 100 hours of shadowing versus someone who has like 800 hours of shadowing as a pre-med is really nothing, because what did you do as a pre-med? You just stood there, right? And kind of followed people around and, you know, asked them questions maybe and then left. So it's negligible. And I would say that the purpose, clinical shadowing is more important than research. If you have an interest in research, great. But either way, like both of those things are just check boxes for you to realize how they fit in with your future as a doctor. Clinical experience is for you to know, hey, do I really want to be in this setting for the rest of my life? Research experience is for you to realize, how does research fit into becoming a doctor? If, let's say, you have a patient with a completely rare diagnosis, how are you going to figure out how to treat it? You're going to look at the literature, right? You're going to look up research articles and find like the one research article talking about this rare disease, and, you know, and then you're going to go from there. So it's really, both of those are for your benefit. And I don't think doing extreme amounts of those is going to help you either way. Just do enough so that you get the idea of how it's going to sort of work its way into your future as a doctor. At least that's my take on it. Okay, so Nathan, thank you. You're welcome, Nathan. Let's see. Is the best way to network through social media or through hospitals that you volunteer at, or does it not matter a great deal? That's an interesting question. So, it depends, right? Like, what hospital are you volunteering at? Are you volunteering at like sort of a small hospital in the middle of nowhere, where it's a community hospital and your doctors, you know, aren't really involved in like academic medicine? In that case, you know, you might want to leverage reaching, expanding your network through social media. With that said, though, I don't think you should ever not utilize your network, because even if it's like an attending or somebody that you know at a smaller community hospital, they may not directly know someone at a med school, but they may know someone else who knows someone else, right? So there's always like that 6 degrees of separation. And so I always, my advice to you guys is be nice to everyone, be good to everyone, and try to just show that you're interested and there and passionate to everyone you meet, because you never know who knows who that's talking about you. And you just never know how that's going to work out. So, if you're at a big academic setting and like the chair of the department where you're shadowing really likes you, heck yeah, you need to like leverage that. If you're at a small hospital and, maybe it's the nurse who has like, her brother's the chair of a department somewhere, leverage that. But at the end of the day, you're not going to know necessarily who's who and who's connected with who. So always be professional, be nice and kind, even at your level. Okay, one way or the other. I think I answered that. Hopefully I did. Hun? All right, so did I answer all the questions? Did I skip anyone? No.
It seems like you covered every single question.
Okay, fantastic. All right,
Nice.
awesome. Well, I am done talking, unless anybody has any final questions for me. No?
Okay, awesome.
Thank you, chat.
Well,
okay.
Well, I want to thank you, Dr. Ahmad, for the informative and ultimately inspiring presentation. I'm sure that we've all learned a lot, and we're grateful that you took the time to really speak with us today. And we just want to give you our thanks, ultimately.
Of course. Yeah, no, it was my pleasure. And like I said, everyone here today, from the creators of this to everyone who's listening, your dedication shows. So keep showing up, keep at it, because that persistence, that dedication, it stands out so much. And I'm happy at any level to be an advocate for you guys. If you want to know how to get involved in the ACR, American College of Radiology, the AAMC, if you want just like any advice, please hit me up on social media, and I'm happy to help.
Absolutely. Thank you so much, Dr. Ahmad. It was a pleasure having you today.
Thank you. All right, take care, guys. I'm out.
And just for announcements for those who are currently attending, if you wish to take the assessment to get your hour for the session, be sure to click on the Google Forms link that's posted in the chat. And all we really need you to do is just take the assessment and pass with a minimum of a 70%, which translates to 7 out of 10 points. So please use one email throughout all the assessments as we are tracking your hours. And as you continue to participate in the program, your hours will be tracked as long as you keep passing the assessments. And at the end of May, we'll be issuing certificates with your total hours for the spring session. And for next time, on February 15th, we'll have Dr. Vera, who's an ophthalmologist specializing in neuro-ophthalmology, orbit, and oculoplastics. And she'll be joining us and telling you everything that you need to know about ophthalmology. So we thank you all for joining the eShadowing session today. And I see a question here. The assessment is going to be open for 45 minutes. Sorry if I didn't mention that earlier. So yeah, I want to thank you all for joining us today. Take care.